Our next session is all about optimizing quality of life. A brain tumor diagnosis and its treatment can impact a patient's cognitive, emotional, and psychosocial well being. In this session, you will learn about the strategies to cope with common areas of distress to optimize quality of life. Our speaker, Dr. Akanksha Sharma, is a triple board certified neurologist, neuro-oncologist, and palliative care specialist with a passion for helping her patients maximize quality and quantity of life, which is so important. She believes in providing person-centered care, focusing not on the disease, but on the person living with the disease, and working together as a team with the individual and their loved ones to come up with a plan of care that best suits their needs. Dr. Sharma also believes strongly that knowledge and education is empowering, especially when going through a serious illness. Presenting with Dr. Sharma is her patient Janice. Please welcome Dr. Sharma and Janice.
Thank you so much. I'm so honored to be here. I'm very thrilled to introduce Janice Armbrust. I've known her for several years. I've had the good fortune. I'm going to let her introduce herself and share a little bit about her background.
Awesome. Thanks. I'm very excited to be here. My name is Janice Armbrust. I currently live in Seattle, Washington. And 4 years ago, in August of 2021, I was diagnosed with glioblastoma. I was 29 years old when I found out about the fact that I would have to spend the rest of my life living with aggressive brain cancer. So then I went through the usual motions of treatment: brain surgery, chemotherapy, radiation. I'm on Optune. Had a potential recurrence in 2022, and since then I've been receiving regular immunotherapy. Every other month I get my MRI and we take a look at what's happening inside my brain. Fortunately, for the past 2 years, not a lot has been changing inside of my brain, so meaning that my husband and I have been very lucky to celebrate stable scans for the past 2 years, and that's why I have this great opportunity today to talk to you all and share my experience. I also wrote a book about my cancer journey to help others and share some tips and tricks with families and friends as well. You can find that on the ABTA website as well. But yeah, I really want to help other people in my situation and their families and friends to navigate this difficult situation. So I think with that, let's talk about quality of life.
Thank you so much, Janice. I'm so excited to be doing this with you. Our goal today is really to give you an overview. Quality of life is a huge thing, and there's many aspects towards it as we discuss. But to give you an overview and some tips and tricks from my perspective as a clinician and palliative care physician, and Janice's perspective as someone living with the disease. So we hope that this will be helpful. Okay. So these are my disclosures, non-relevant to today. So these are our objectives. We're really trying to help to give you some practical tools, strategies, and tips to enhance well-being and quality of life, because we know that quality of life is quite complicated in a patient who's living with brain tumor. There's many aspects that are impacted when you have a brain tumor. It's how you feel physically, it's how you feel cognitively, how you feel emotionally. It has an impact on your social life, depending on how early you have deficits from the brain tumor, you might be more unable to participate socially, be unable to take care of your own needs to commute or go to work. And then, of course, there becomes the financial burden of care, which in the United States is incredibly high, especially for patients with brain tumor. And there's also the spiritual aspect of wondering why this happened, where do we go from here, and what will the future look like? So quality of life is not one thing, right? It's different for everyone. It also evolves over time and changes based on where you are in the journey, what's happening to you, and what's happening to your disease, as well as the treatment you're getting. It involves more than the patient. That's strongly my belief. So quality of life, how you're feeling as a patient, is incredibly important, but how your caregiver is doing is also going to impact you. If your loved ones are stressed and unhappy or burdened, you will feel that, and vice versa. Your loved ones will feel your stress and your pain. So especially in brain tumors, more than anything, because the care partner plays such an important role in a patient's life, we really want to consider quality of life as involving more than the patient. And it's important to note that it's impacted by disparities in healthcare inequity. in the question and answer session, and for the last session, we discussed how sometimes there's not access to neuro-oncology care or to centers of excellence, and all of that impacts what kind of care and resources you get in your community. So quality of life in action. I'm going to have Janice talk about what quality of life means to her.
Yeah, and I really want to emphasize something you just said too, Dr. Sharma, that quality of life is truly, truly different and can mean so many different things for different people. And I think quality of life also really depends on someone's priorities and values and, you know, their overall situation. So yeah, for me, quality of life means being able to go on adventures with my husband and our friends. It means that I get to spend time on the beach. I get to go on backpacking trips. I get to go rock climbing. It also means that I'm able to go to work. I get to do my grocery shopping, and I live life fairly independently. And all of these things are really, really important to me. Other patients probably care less about whether they can scramble up a pile of rocks, but it really, really matters to me. But I do know many glioblastoma patients who have far more severe side effects than I do. And for them, quality of life means something entirely different. So, for example, I've been mentoring fellow brain cancer patients through Immerman Angels, and one of them was I was talking to there had really strong cognitive side effects. And so after her surgery, she lost most of her ability to speak. So for her, it was so really important for her quality of life that her friends and family took the time to and patience to speak with her and try to communicate and really have meaningful conversations with her. And so yeah, all that to say that I think it's really important to understand what quality of life means for each patient and for their loved ones too. And so yeah, with that, I'll hand it back over to you, Dr. Sharma, to tell us more about why quality of life is even so important to begin with.
Yeah, and I just want to again emphasize that the quality of life is individual. It's different for each person and it will change, and that's okay. It changes throughout our journey even without serious illness. You know, what quality of life meant for me when I was in my 20s is different than what it means now, especially after I've had a child. So it's going to vary and that's completely okay. And going back to some of the questions from the last session, quality of life plays a role in decisions like clinical trials. Like, where do you go for care? What do you do? Which doctors you go to? Because if your quality of life does not involve getting on planes every 2 weeks, then you might not go to a clinical trial in another part of the country. So it's important to consider this from the beginning. And as Janice said, why should we make quality of life a priority? So some of it is pretty obvious, right? If you don't have good quality of life, then you won't feel good. You don't want to go through treatment. You don't want to go through all the things that you are having to go through, like radiation, different trials or treatments. And often patients who have poor quality of life are just done. They're tired. They don't want to go through things. Their treatment is incomplete, and that leads to worse outcomes. And in addition, it's very painful, right? It's very painful to have a poor quality of life, be unhappy, and live each day like it's not optimized. So how can we optimize our quality of life through this journey? And that's what the rest of our presentation is going to focus on. So before we go into each aspect of care, we just want to give you some big picture thoughts. So most important takeaway when Janice and I were thinking about this was that it's very important to talk about it. So even when you're not explicitly talked about, if no one says, how's your quality of life or how are you doing these days, it's still important to talk about and say, bring it up yourself. I would like to tell you about how I'm feeling, and I want to know if this is expected or not expected, because especially in the early phases of our diagnosis, we're really unsure of what's going on. Is this what I should be experiencing or not? For example, for radiation, some people go through horrible fatigue, and they don't know, maybe this is just normal and I should talk about it. But sometimes that fatigue is because they're anemic, and that's something we could address and we could make you feel better. So it's also important to bring it up to your physician that quality of life is important to me. Can we discuss that this treatment you're giving me, how is it going to affect me day to day? Am I going to be able to do the things that are important to me, which might be as simple as cooking for my child, or it may be as active as rock climbing. Think about what quality of life means for you and what a typical day feels like or should feel like. What are your main issues that are affecting your quality of life? And have you talked to your team about this? Why or why not? So think about what those things are. For example, with Janice and I often talk about her travel and where she's going next. And if her treatment is going to impact that schedule, then we adjust her treatment schedule. Or if I'm concerned that she might skip treatment, then we discuss that. So, but it starts off with her saying, it's very important for me to take this trip. And what can we do to make sure that I can take it? Bringing up issues as they happen. This can be a challenge, and we're trying more in practices to have something that helps us monitor our patient's life, because sometimes you think of all the things you want to tell your doctor, but when the visit happens, your brain is blank and you forgot your notes, or you thought you would remember it, but you don't. So sometimes it's helpful to use a patient monitoring app if your center provides it, or you can send an email or my chart message, or you can record it on a notes app on your phone. So there are ways that you can make it more accessible, but the sooner you can do it and the sooner you can note those things down, the better chances they are that your team can step in and help optimize. And there might be sometimes very simple changes. I recently met a patient who wasn't sleeping, and we found out that the steroid dose was at 9 p.m. So that's a very simple change we can make to help improve his sleep. Or if patients were taking Zofran and they're severely constipated, they don't realize they can bring that up, and you can just switch to a different nausea medication that's not going to cause as much constipation. So I think there's small, simple changes that you can do to optimize your quality of life, but you'll only hear about them when you bring up the issues that are happening. Janice, anything you'd add to that?
Yeah, I think for me as a patient, I always in the beginning hesitated very much to bring all my symptoms and side effects up to my care team, because I'm like, oh, they're so busy. Am I going to bug them with this? Like, it's just fatigue. Like, they don't need to know every single time that I don't sleep well at night. But like, I feel what I've learned over time is that you all really do care, and it's truly more helpful to send more messages versus less messages. And so I've tried to just like communicate as much as possible to get the best care that I can possibly get and get the best quality of life. And then I think the other thing that I will say is that I also mention every single side effect to my husband, kind of almost by default, because I'm like, oh, I'm so tired. And then he's like, oh, did you tell your care team about that? I'm like, no. And so then, we both kind of can at least take note of it, so that, to your point, we can make sure to bring it up in our next appointment if I don't send a message in advance.
Yeah. And I think the sooner we can know about it is also important, because it's often cyclical. So if you have been taking Zofran and you're very constipated, it's actually going to make your nausea worse because everything is sitting in your belly, and then you're going to be throwing up, not eating well, and then we're going to say, why is this person throwing up so much? Maybe we need to stop the chemo. But in reality, it's because the constipation started like 2 weeks ago. So those kinds of things are really important to mention. So let's start with the physical aspect of treatment. So these are some of the most common side effects we see. Now, we can't mention every single side effect, and your individual journey might be different, but this is what the literature tells us, or what most of our patients say. Fatigue is the number one symptom in brain tumor patients. Fatigue is caused by the tumor, it's caused by the treatment, it's caused by radiation and chemo. It can also be caused by steroids. Steroids might help with fatigue initially, but then over time can cause fatigue and affect your hormones. So fatigue is really difficult, and it's a very common symptom. There's also the side effects of steroids. There's pain, can be nerve pain, muscle pain, bone pain. And then, of course, some patients will have weakness from the very beginning, or they might develop weakness during the course of their disease. This might be generalized weakness, or one side of their body is weaker. The other important symptom is seizures. So some patients might have seizures from the beginning, some might never have a seizure, and some might have seizures in different times, depending on recurrence or how their tumor is doing. And seizures, of course, are very difficult to witness, but they're also difficult to go through. And we want to try to optimize seizure control, because that will affect your cognition and your quality of life significantly. So these are just some of the physical aspects. And then we'll talk about what we can do, because that's what we want to make sure you know what you're experiencing, but we want to make sure you have tools. So for fatigue, exercise is incredibly important, and Janice is going to comment on that. And then for steroids, I always say the smallest possible dose for the shortest amount of time. So often this is something that's missed in the first few weeks, especially after surgery. You're on a high dose of steroids and no one has talked to you about reducing it. But steroids actually can be counterintuitive if you've taken too much for too long. So they can be helpful in small doses for short amounts of time, but you should never be on high doses for prolonged periods of time because they actually affect your muscle function. They break down muscle, they make you tired, they affect your sugars, your blood pressure, your skin, almost everything. So really trying to talk to your doctor about steroid dosing. And then for weakness, again, physical therapy, and seizures, as I mentioned, getting good control of your seizures. Now, for fatigue, the only aspect of treatment that has, of all the trials we've done and of different lots of medications we've tried, which we have done a lot, the only thing that has really shown positive benefits is aerobic exercise. And I know Janice really is active, so I'll let her comment on that.
Yeah, I mean, yeah, and I will also say that, I'm privileged that I can be so active. So I do a lot of high intensity workouts. We do go rock climbing a lot. I go hiking a bunch. I go running. And I know that I'm fortunate that I can do all of those things as a brain cancer patient, but I think it also like you can do whatever suits your body and your health. So I think you don't have to go crazy if exercising to you just means I'm gonna go outside and walk around the block once. Like that's how I started. Like I didn't go out of brain surgery and was like, okay, all right, now let's go, run a 5K. Like that's not how it works. So I think do like listen to your body is the most important thing when it comes to exercising. But for me personally, like I do feel like it helps with fatigue and it also helps with my mindset and like kind of not thinking about cancer and staying positive. The other thing I will add to that too is like nutrition, I think, is really important for fatigue and also for exercising, but as well. So like I've asked most of my care teams like, hey, can you hook me up with a nutritionist as well? So that I can make sure that I eat a diet that fits my goals as well, and make sure that if I exercise a bunch, I also, get the nutritions in as well.
That's a great point. And most centers, cancer centers will have a nutritionist you can meet with, and it's often covered by insurance. Most of the time, it's covered by insurance, I should say. The exercise has to be tailored to what you can do. But what I found is that most patients can do some level of modified exercise, but often that means they have to talk to a physical therapist. It might be as simple as chair yoga, it might be simple as stretching or range of motion, or it might be more complex. It might be walking every day. But especially when patients start radiation, I tell them if they can do even 10 minutes every day, it'll help them feel better. And that's actually been found to be true. Cancer support communities, different local cancer groups often have free sessions like for Tai Chi, Qigong, yoga that you can attend online, which can be really helpful. So next, we're going to talk about the cognitive impact. So there are a lot of things that are impacted with the brain tumor, and it's going to depend on where your tumor is located, where you had surgery, what kind of radiation you got, and how much radiation you got. So again, your story is going to be different. This is the most common things we notice in patients with brain tumors. We notice a change in executive function. So this might be what initially you're not noticing as much, but then you start noticing things that were simpler to do before are taking more time. Things that came easy to you, you have to think about a little bit more, a little bit longer, maybe even a lot longer. The steps into doing something take more out of you. So that's executive function. It's how we execute daily tasks, even simple tasks like drinking a coffee or making a coffee. Some of the things that are really also that impact the family and also the patient is lack of motivation, which we also call abulia, where patients just don't feel like doing anything and don't feel like participating. That can be really hard because we want them to do physical therapy, and often that happens with frontal lobe tumors. And then memory loss, of course, impacts everyone. It's usually a short-term memory loss. Sometimes it starts with radiation or after radiation, but that can mean that you forget small things, including the symptoms you're experiencing, or you might forget where you have to be or your appointments and things like that. So these can be some of the common cognitive side effects. Any comments on that, Janice?
Yeah, I think the one thing on cognitive that I always wonder about is for me what I'm noticing is I do feel like I'm less focused, and I also have this odd cognitive side effect where I can't remember faces anymore. So if I meet new people, I forget who they are, basically.
Mm-hmm.
Anyways. So and then the confusing part becomes, was this there before surgery, or did it come with surgery? Like I always struggle to really recall, like maybe I was never as focused as I think I was. So is
Mm-hmm.
this like I'm almost gaslighting myself a little bit there sometimes, and it's a
Mm-hmm.
weird balance that I need to find with my care team a lot of like, is this is this a new change? Was it like this beforehand? And so I go back to, friends, family, my husband, and I was like, wait, did I struggle with this before the surgery? And so I kind of feel like they can help validate a little bit, and then that helps inform what kind of support and care I need to get. So I ended up
Mm-hmm.
getting occupational therapy to help me learn how to focus again and learn how to like focus on tasks that are, not as stimulating to me. So I
Mm-hmm.
needed to relearn that a little bit because it did in fact, like, it was a change after the surgery.
Yeah, so it's going to be dependent on your premorbid function or your how you were doing before surgery, and it's also going to be one of the things that's important, as you know, Janice, is that you become more hypervigilant. So you're more aware of new symptoms and wondering, is this the tumor or not? And the only way to know is to really talk to your team and see, could my tumor be doing this or something else going on? Often mood changes, which we'll talk about a little bit later, can impact your cognitive function. So really having your mood under control is going to help you feel better and think better. So what can you do for your mood, for your cognitive function? So there are actually, there's evidence from non-brain tumor literature. So patients with dementia or patients with brain injury, and I sort of pull it from there because it's an injured brain, and how do we help the brain recover is quite similar, even though we need more studies on this in brain tumors. One of the things that has come up really important in the last few years is more activities. So the more new skills you make your brain learn, the more connections the brain is going to want to make. So it's plasticity, the plastic nature of brain. And we used to think that it only happens in young people, but at any age, new skills help. And there's evidence to suggest that the more social you are, the more new skills you're learning, the better your brain will recover. It can be as simple as painting, picking up a new craft, picking up, going to a class, an art therapy class. Art therapy is actually a really great option if it's offered in through your local cancer support group. Speech and occupational therapy, as Janice mentioned, these are specialists who are trained in this and can help you. Unfortunately, the access varies, so it may be something that's in your community or not. But these often, if they're neuro trained, it's even better. There are medications that we use to help with the cognition and with fatigue, but they vary and they all have some level of side effects, but we'll talk about mood later in this talk. Again, exercise helps everything, including cognitive functions. And then there are practical tools that you have to do. You might need to start keeping lists, use your apps on the phone, voice memos, recording on notes. Often patients will record their session with the doctor so they can remember what happened later, especially if they're coming alone, and talk about it. Take the stigma out of it. One of my other patients, really, every time she joins a meeting, will say, I might mess up my words, but I'm trying my best, and hopefully that's okay. And so it just prepares everyone, but also makes you feel more confident because you're owning up to what's happening. Any comments on that, Janice?
Yeah, the last part definitely resonates because I now do that too with my not recognizing people. I warn people when I meet the person that like, hey, next time we cross paths, I might not recognize you immediately. So just like help me out here. And I also find my friends in the room, like if I go to work and I'm at the office and there is a bunch of new people who I haven't met before, I'm like, hey, do I know this person? What's the name again? And so I think like asking for help with these things really helps. And then I think the most important thing from my perspective when it comes to cognitive, like what you can do is like give yourself some grace and be patient with yourself, be patient with your loved ones. I think we have a lot of high expectations of ourselves sometimes, and it can be so frustrating to deal with these cognitive deficits. And so for me, for example, when I am working and I notice like, oh, I'm really cluttered right now, I'm so disorganized. Why am I so disorganized? I get really frustrated with myself. And then I have to remind myself, like, hey, it's okay. Like, I gotta just take a step back. It's okay. We're not machines. We're all just humans. You don't have to be organized. You can ask for help. It's okay. So I think that's kind of how I deal with my cognitive issues.
Yeah, give yourself grace. That's very important. Okay, so then that ties into tightly to emotional and psychological component of brain tumor. So your tumor is in your brain, and so it's going to impact the function of the brain. Sometimes, because there's so much stigma on mental health issues in our community, I like to point out that, one, there shouldn't be a stigma, but even if you're feeling bad about this, it's not something that's a loss in you, or something that's wrong with you, or something that you missed, or a deficit in you as a human. You are going through something really major that's directly in your brain. And then when you have surgery, it cuts through your brain. When you have radiation, it affects the brain. So the neurotransmitters in your brain are going to be affected. It's a biochemical thing. It's a mismatch in the levels that should be there. And so it's no wonder that you're going to have some level of emotional effects at some point. In fact, some people tell me that they feel different in a good way after surgery, and some because the tumor was causing a lot of problems. And often people say, oh, they feel new anxiety or panic or depression. So it's important to remember that it's all tied together. But if you are anxious and you're not sleeping well, or you're depressed and you're not functioning as well, it's going to affect your cognitive and physical function. So it's very important to bring this up, even though this is probably something that patients bring up the least in my practice, and I try to ask about it consistently. But people are still worried about bringing it up, but it's important because we need to address it so that it doesn't impact the other things. Some patients can also have personality changes, especially if they're frontal lobe tumors, and this might be something that the patient doesn't is not as aware of, but the caregivers are. So talking to the caregivers about their experience is very important, because sometimes that manifests as anger or irritability, and they don't mean anything, but we want to make sure that we're addressing it so everyone is safe. So what can you do about this? So medications are one of the first line treatments for neurotransmitter deficiencies. So, but the problem is that not every medicine works for everyone. So some of the frustrating aspects of this step is that there is some trial and error. There are a lot of common medications like Lexapro, sertraline, Zoloft. There's a new one called Pristiq, but we need to ensure that firstly they don't interact with your current medications, and it's not a one size fits all. It's going to depend on you and what works for you. The other problem with that is that it may be a combination of things that works for you. You might need therapy and medications, or if you don't love taking medications, you might try therapy alone. But we still, again, have to make sure that we review all the options and think about it together with you. Support groups can be really helpful. Again, exercise is very helpful. It's been shown to improve your endorphins and the neurotransmitters in your brain. It'll vary depending on how much you can do, but some people do feel good after exercise, so that's important to think about. Talk about it, especially if it is making your home life challenging. Make sure you bring it up, talking about it at clinic appointments. And I have found that there's a lot of data on coping. How do you cope with your illness? How do you cope with the new changes that are coming? How do you cope with the uncertainty of the future, which the last session talked about? But the better patients cope, the better they do, and the better their emotional health is. And so there are actually skills you can learn to help you cope. There's a type of therapy called acceptance commitment therapy that can help you do that, but also things like the gratitude practice, or talking more about gratitude and things that are going well in your life, can be a helpful coping skill. Janice, anything to add there?
Yeah, I think this one is tricky because it ebbs and flows more than the first two. So with like physical and cognitive side effects, it's a little bit like once you've taken care of it, hopefully you're done with it a little
Mm-hmm.
bit. But emotional, I feel like it just changes all day, every day. Um, so for me, it's been 4 years since I was diagnosed, and I still think about cancer pretty much every single day. It just pops into my head, and most days I acknowledge it, and it's like, oh, yeah, that sucks, but I still love my life, so I'm still happy. But there are definitely some days where I get really mad about it, and I get really upset and maybe a little depressed that I don't get to live the healthy life that I envisioned. Um, and I did see a therapist for probably almost a year after I first was diagnosed. And then I only stopped seeing her because I moved cities, and so she couldn't see me anymore. But I would always go back, like highly, highly recommend therapy to work through anything in your life, really.
Thank you. And there are therapists who are serious illness trained, and I often recommend considering a serious illness therapist. Now we thankfully have a lot of virtual platforms that can offer therapy. And so even for patients who might be in remote areas, it might be something that you can look into. A lot of those virtual platforms take all kinds of insurances. So this also connects to social, as you see the trend here. Everything is connected to another thing. If you're physically disabled, you might be homebound or bedbound, unable to work, and that increases your dependence. It also increases isolation because often when someone's diagnosed with a serious illness, there's initially a wave of support which kind of settles down and people sort of get disinterested or not as active or don't know what to say or how to be around you. So isolation is a big part of this journey, and we want to recognize that. And then the caregiver becomes sort of the sole person who's involved. So what can you do about that? This is a tricky one. I think the one thing that I have found with patients who like support groups or who are willing to give it a chance find that helpful after a first couple sessions, because those are the only people who understand what you're going through. So Janice is here today because she can really give a perspective of someone who's walked those steps. And if you like that you should really consider finding a support group in your local community, or there's a lot of virtual ones online now and national ones. The ABTA has support groups. Use your village, find the people around you who are showing up, who are coming up, and who want to help. And often people are nervous to take help, but I always say that it's always a cyclical portion. They're going to need your help one day, but also people really like to help each other. That's our human nature. That's what makes us human. And so giving people an opportunity doesn't mean that you're taking something from them, but you're giving them an opportunity to be there for you. There are also resources through insurance, community organizations, or churches and religious organizations. But the most important thing that often I help patients accept is that it's okay to ask for help and it's okay to get help. Janice?
Yeah, I think you pretty much said it all. I think asking for help is so hard, and it almost for me took a little bit of a mindset shift to really not only learn how to ask for help, but also learn what to ask for, and hopefully, others can help you figure that out as well. Like you don't have to identify all your needs for support on your own, but I really like sometimes I sit down and I'm like, do I have to figure this out on my own? Like, what can I get help with right now? And it's, my husband too. He's like, how can I help you? Can I do this? Can I do this? I think for like caregivers and friends and families, it's also, don't put it on the patient. Like, put it on the whole village to figure out how can everybody best thrive in the situation, in this difficult situation that you're in.
Yeah, very good. Thanks. Okay. And move on to financial. So this is part of the care, a part of the quality of life that to me is most personally frustrating right now because we are living in a very difficult time with healthcare. But this is a huge problem. One, because patients with brain tumors, especially malignant brain tumors like glioblastoma, about 40% of them can't work within the first 2 months of diagnosis, and eventually at some point the large majority cannot work. So that means there's a huge financial burden. Insurance is affected. There's restrictions to driving, so you can't go around as much. That affects you socially, but also your caregiver has to do more for you. There's the added cost of parking, meds, travel if you're going for a clinical trial. Financial planning and thinking about the future can be really challenging cognitively for patients with brain tumors. And we also have to think about the fact that the majority of patients with glioblastoma are going to need caregiving at some point, whether that's between surgery or recurrence or different times of the journey. And caregiving in the United States can be very expensive, depending on where you're living. So it's a very difficult part of care. And I know that it sits on people's minds often. It's not something that even doctors know how to advise people on often because we have not been trained well enough on these aspects as well as we should be. And also it's constantly changing with the health insurance and the system that we have right now. But what are the things you can do for that? So I do have some ideas. One is that most cancer centers have social work, and often many of them have financial counseling. It's something that you don't know about unless you ask for it. So seeing if you have a social worker or financial counselor that you can talk to. Organizations like the ABTA, the National Brain Tumor Society, Musella Foundation, Brain Tumor Network, there's many similar organizations that are out there that will provide financial grants, or you can reach out to get help from a financial counselor or to at least talk to somebody. You can ask for a care manager through your insurance. This is something insurance doesn't advertise, but it's something that's available. This is somebody who's going to advocate for your drugs to be covered, to reduce your copays, or to get surgeries and radiation therapy covered. Not all insurance is provided, but it's good to ask. And then we really need more patients with brain tumors to talk about how financial burdens of care affect their life. And this can be something that's very important when you reach out to your local representatives, because if we don't get better health insurance and better care for our patients, then the care is only going to become more inequitable. And your stories has a huge impact on lawmakers. As your stories really impact people. And so something to think about as something you can do. Janice?
Yeah, I mean, I've been advocating in that area too because yeah, we talked about this a lot too. This is probably for me the biggest impact on my quality of life. I'm so stressed about this aspect for several different reasons, but yeah, like there's so much to unpack here from, if I lose my job, I lose my health insurance, and then how do I afford my care? Like, does that mean that I'm just gonna not get care? So very stressed about that. And then, yeah, the portion of how do I even plan for retirement when I'm like statistically not even supposed to be sitting here right now. So it's all of those things. And then in addition to that, kind of a little hint of survivor's guilt of like, I'm so fortunate that I even have this problem as a glioblastoma patient. And, why, like, should I just spend my money and live my life to the fullest on behalf of everybody who can't do that? So it's very challenging for me. And I wish there was an answer. So I
Mhm.
think we definitely need to advocate more and talk more about it to work it out.
Yep, absolutely. And then the last aspect is spiritual. Again, something that's not talked about enough is existential distress. And Janice kind of has touched upon it a few times, is this uncertainty of, I don't know how long I have, and I've already sort of outlived my expectancy. So what happens next? So it's a distress of existing because you're not sure what'll happen tomorrow. And then in the other side of that, or related to that, is anxiety about death. And this can start in patients who have serious illness from the very beginning. There's fear of the unknown, fear of uncertainty, fear of the future, disillusionment because you thought of a certain way your life would go and it's changed. For patients who are religious and spiritual, this can mean really coming to terms with the fact that your faith maybe that this happened and you don't know why it happened and why it happened to you. So this can be very difficult, not talked about often. But again, there are ways that you can handle this too. There are meditation and mindfulness studies that have shown really good outcomes with patients who start to learn mindfulness techniques, even if they've never meditated before or practiced mindfulness before, because it's a way of being present in the moment. So it takes away some of that anxiety about the uncertainty in the future. Gratitude practice has a ton of evidence, like lots and lots of clinical trials. If it was a drug, it would be sold on the market. But it's basically a daily way of talking about what you're grateful for, and it has shown to have benefit again in both of these existential distress and death anxiety. There are some amazing researchers who are doing studies in neuropsychology for brain tumors, including the Dr. Lowen's lab in Virginia Commonwealth University. A lot of those studies are accessible online virtually, and you can be part of them and get these amazing resources through online sessions. So it's something to explore. That includes things like acceptance commitment therapy. For some people who are religious, talking to your spiritual leader can be helpful, and talking to friends and family. And then treating anxiety, under the underlying anxiety doesn't always treat spiritual distress, but it definitely makes you feel better and want to do these other things. And in times like this, where there's a lot that we can't control, even in our community, it's important to focus on what we can control. So how can palliative care help with this? So this is the last part of my presentation, is to talk about what are some skills or what are some resources that can help you get to all of this. So palliative care is not hospice. This is still a very common misconception. Palliative care in the US is not hospice. It's not the same as care at the end of life. Palliative care is a bridge. And so I like this video that I will play, and hopefully this will work with sound. That's okay. So if you look up palliative care is you as a bridge, then you'll see this great video that I really suggest. It's 1 minute long. But palliative care is services that are offered to you at any point of your illness, diagnosis onwards. And it's not just at the end of life. Palliative care at the end of life is called hospice. But palliative care can be available at any point. It does not require a diagnosis that is life-limiting or terminal. It just means that you're living with serious illness and you need a group that's focusing just on your quality of life. So the definition that I like is palliative care alleviates suffering. And so suffering comes in many different forms, as we've talked about. And one of the ways that palliative care helps with that is that it helps you navigate all those different areas. and it helps you find resources and skills and helps you find tips and tricks for it. So it ties together your care, especially in brain tumor care where there's so many specialists, neurosurgeons, radiation oncologists, medical oncologists, neuro-oncologists, all of these doctors, and you're just kind of overwhelmed and wondering what is the big picture, who's thinking about the big picture, and that can be your palliative care specialist. Care in research, it's been shown that care that's aligned around palliative care principles improves both quality of life but also quantity of life. So again, going back to patients who feel better, do better, live longer. And so it can be a really great tool. It's the pursuit of quality of life. And often it's available to you through your cancer center. If you're in a community hospital system, it may be available through a community doctor, but it's something that you often have to ask for a referral for, or you might ask, is there a palliative care provider that you recommend that I see? How can you access palliative care? As I said, ask your oncology team, ask your social workers or nurse navigators. You can ask for if you're in the hospital, you can ask your team to place a palliative care referral. And there's a website called getpalliativecare.org that helps you find resources. And you can get palliative care anytime. It may be more helpful when you're symptomatic or if you feel your quality of life is not good. And if today after this talk, you realize, a lot of these things are not optimized for me and my team is not able to do enough. And so you can definitely at that time ask for palliative care and say, like, maybe palliative care is what will help me. Another time is when you're curious about the future. In the last session, there were a lot of questions about how do I choose a clinical trial? How do I make decisions about traveling? Where do I find the best team? Those are actually some things palliative care helps with, is helping you make those decisions or like what's right for me. And also another thing that they help with is when teams aren't communicating with each other. Often patients say, I'm hearing different things from different team members, like the neurosurgeon is saying this, the medical oncologist is saying this, they're not on the same page, neuro-oncologist is saying this. And so those are times where you can have palliative care help translate the healthcare system and translate the language for you. So it's someone who's in your corner. Janice, any thoughts on palliative care? I know that you and I work together, but any other thoughts on that?
I just recommend it. I think like it sounded scary when I first like saw my very first palliative care nurse, and I was like, oh God, what is she going to talk to me about? It was a little because I think I was in that stage where I confused palliative care with hospice, and I was telling my friends, like, oh, I'm going to see palliative care, and they're like, what? That's not good. I'm like, no, it is good. And yeah, it took me a little bit to understand what it's really about and that they're truly just, yeah, trying to provide services to improve quality of life. And yeah, I think like asking to see a palliative care nurse can only bring goodness. So I recommend it.
Thank you. So those are our tips and tricks. We wanted to leave time for questions, and so we'll stop here and take questions. Thank you so much for having us, and thank you for giving us the time to be able to talk about this very important topic.
Yes, thank you.
Thank you so much, Dr. Sharma and Janice. And Janice, thanks so much for being here and just sharing your personal experience. I'm sure, it's very relatable to the audience members here today. So we have a few questions coming in, and feel free for both of you to chime in where necessary. But one in particular is asking the question to how to parent and still give your children moments of joy amidst a diagnosis.
That is such a good question. And I have learned a lot from my patients who have young children on this topic, and I try to be aware of resources for young parents, and unfortunately we don't have as many. But one of the things I've learned from my patients has really been actually being present and being mindful. And so there is a lot more uncertainty added in your life when you're diagnosed with glioblastoma or serious illness like glioblastoma. But reality is that even every day we are dealt with things that we don't know what tomorrow will bring. And it's a practice that we should all be doing, like making sure we make the most of our day, making sure we spend time with our children and giving them moments of joy. But when you are faced with this illness, you get more aware, and it's sort of brought sharply into view that I don't know what will happen. So why don't I make sure that I do the things that I want to do with my children now? So take that trip, go to that, place that you wanted to go to, take them back to your childhood home, all the things that you were thinking we'll do eventually. I always say the better you're doing, the time is now. The best time is now, because why wait? If things go well, and like Janice, you're here years later, then you can do it again. But finding those moments where all the things you want to teach your children, all the things you want to share with them, you start bringing it up earlier. It's something that I've learned from my patients, where I, even for with my child, I'm doing it earlier. I'm not waiting. If I get an opportunity, I'm using it. One of the things I heard recently, Suleika Ja would say, she's an author who lives with recurrent leukemia. She said, it's very exhausting to live every day as if it's your last. Like, it's not a good way to think about things for her. And so she says, I live every day as if it's my first. And I find that doing that with children is really amazing, because children do still have that wonder and that awe and that joy of life. So when you're living with a diagnosis like this, sometimes the simple needs of the children, like they just want to go to the pool, they just want to have a peanut butter and jelly sandwich with you, those things can actually remind you of the normal things in life. And so those moments of joy don't have to be these huge, like Hawaii trips or going to Disneyland. They can be very simple things that you are just being more conscious about and doing with them now. So more time. Yeah.
And I would also add, I don't have any children, but my dad passed away from leukemia when I was 7. And as a child, in that perspective, they've kept me very, very sheltered from everything that was going on at the time. My dad spent most of the days at the hospital, but eventually was transferred home, and I was basically not spending a lot of time with him. He wasn't able to spend a lot of time, but nobody was really sharing with me what's going on. There were no transparent, my family is German, so there were no transparent, open, emotional conversations. We don't do that. But in hindsight, growing up with all of this over the years, I think there are a bunch of things that, and don't get me wrong, I love my mom. We have a great relationship, but there are a lot of things that could have been done differently, like getting me to see a therapist as a child, having more transparent, obviously, I didn't need to know everything, but kind of better understanding what was going on with my dad in the next room while it was happening. I think, like, instead of processing it when I was in my 20s, I could have processed it like at the time with professional help from a therapist and with like good emotional support from my parents. So I think, yeah, just an additional perspective, I guess.
Yeah, and I think one thing to connect with that is children often aren't looking for joy all the time. They're also looking for honesty from you. So sharing what's happening, so they're not thinking it's me or it's my fault or my reason that my parent is not happy. There's an excellent book called You Can't Do It Alone by Maria Whitesell, which is about her experience with GBM. Her husband had GBM, but her child was very young at the time. So I highly recommend it, because she wrote it with a grief therapist, and they have some really practical tips on how to work with children.
Thank you so much. And I just want to plug in an organization called Pickles. They actually supply supportive options for kids whose parents have cancer. So feel free to check them out. We
Yeah,
also have
there
a
are many other groups like that, like Camp Kesem, and
yes.
yeah, Pickles is amazing too. I follow them on social media, but there's many groups out there that will arrange camps for the whole family, or for just the children to connect to each other.
I will also
Thank you.
say, a resource we don't always tap into is like school counselors. And I do think just, notifying the school counselor to just, or teachers to just kind of look out for any change in behavior, because kids do oftentimes pick up on things that you don't think they're picking up on. And you may be protecting them, but they might exactly know your feelings, they might mirror your feelings. So I do think having kind of preventatively involving counselors and therapists can be helpful, rather than like getting a therapist involved after
Hmm.
things have um, kind of gone out of control with their behavior, for example.
Hmm.
Thank you. All right, next question we have here is there was a few questions that kind of had this underlying theme of like when undergoing treatment, it could potentially affect somebody psychologically. But then I also know with somebody being diagnosed with a brain tumor, there could be layers of things going on. There could be a pre-existing psychological issue, or it
Hmm.
could just be the effects of where the tumor is located. So the question I have here is, can psychiatric meds be included when somebody is undergoing treatment? And maybe how to navigate going about maybe differentiating the two or understanding if it's a
Hmm.
causation issue.
Yeah. So in terms of causation, it's really timing really makes a difference. So if this all started right around the time of diagnosis or a few weeks before, a couple months before, then it's probably something that the tumor caused or worsened. And it can be very difficult if they already have psychiatric issues early in the course, because it is going to get worse before it gets better during radiation and post-surgery. So it I think later in the course, it can be even more intertwined, because depression might get worse, and we don't know if that's from the tumor or from the situation or pre-existing history. But early in the course, it's more the tumor might make things worse. And so to me, it doesn't matter really what the cause is. It matters that how it's affecting the patient and how it's affecting their loved ones. And if it's negatively affecting their day-to-day, then we have to treat it, and we have to add the right medications to the regimen. The problem often becomes is that psychiatrists, just like palliative care doctors, are in short supply across the country. And those who specialize in oncology or psycho-oncology are incredibly rare. So often there are people in the community who are good psychiatrists who are comfortable with cancer patients, and you would find those through like a local group or through Google search or things like that. You can also use some of the online platforms for psychiatry that will take insurance, that will have a variety of psychiatrists who are licensed in your state, who can work with you on these specific disease specific issues. But it's not something that I think to just push through and get through, because it can be really disruptive and traumatic for the whole family.
Thank you. Any other additions? That's okay. All right. Next question is how to decide when to stop treatment and balancing quality of life and alongside with that.
Yeah, this is a great question. It's something that comes up often with patients who just see me just for this specific question. Is it time for me to stop? And it's very difficult because it's very individual. So part of it goes back to the questions we mentioned in the beginning, like what is quality of life to you? And is it something that you are living right now? And if it's not, do your doctors think that it's something you'll get to? And this is a very important and honest question. Is like, okay, if this next treatment gives me X number of months or X number of years, or what does that time look like? Often people will just say, oh yeah, let's do this treatment. I'm hopeful it'll work. It'll give you more time. But the part that is mixed out is like what that time looks like. If your current quality of life is not acceptable and this treatment will just extend that quality of life and you won't get better, then it may be something that's not for you, and then might be time to consider stopping treatment. If your current quality of life is acceptable, but this treatment might make it significantly worse, then it might be something that you try, but then stop if it's not working or if it's making you feel worse. And if your quality of life is acceptable and you think that more time would be good and this treatment is not a high burden treatment, then you try it again. So it really depends on how you're doing in that moment and what is acceptable to you. When you're looking at second or third recurrences, most treatments are 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 not going to have dramatic improvement in time at this point. We know that most of them add a few months at a time. Sometimes there are rare treatments that add a lot more time, but it really depends on if you are doing well enough to go through that treatment and if you want that time in this current quality of life.
Great, thank you. Next question we have here is a patient who stopped treatment and is actually entering into hospice. Should they continue other therapies such as like speech therapy or physical therapy? What would be your recommendation?
Yeah, this is a really controversial thing. It shouldn't be, but it is, because hospice in the United States has um, always excluded therapy. We are hoping this will change in the future, because this was not based on what's best for the patient, but what's best for the system and financial burden. Right now, there are some hospices, really big hospices, that will offer occupational and speech therapy. So it's something to ask if you're considering a hospice. Does your hospice cover occupational and speech therapy? They take it out of their own pocket pool, or they might bill insurance. Um, and then there are often people who continue private pay occupational therapy or speech therapy, which depending on where you live can range in cost. And if it's something you can do, then that's great. But yes, getting on hospice usually in most cases means stopping therapy. And that therapy may or may not be useful. So sometimes physical therapy, if the patient's like, I don't want to get up and do it, I say it's okay to stop. But if the speech therapy is something that they like to do, it keeps them engaged, it adds more quality of life for them, then it's something that you could continue, and you might ask your hospice medical director if that'll be accepted for a short amount of time. So there are some ways and tips and tricks that your oncologist can help you navigate with your hospice team, but it really depends on where you're located. But there's no black and white to say that you should stop therapy once you're in hospice. It's not from a clinical perspective that we stop it. It's really from a financial perspective, unfortunately.
Great, thank you. We have one more question, and this one's for you, Janice, asking about what is your regimen? Like, what were the treatments that you underwent? And any just advice for being a warrior as you describe yourself that you can offer to patients listening today.
Yeah, thank you for that question. And Dr. Sharma, I'm happy for you to weigh into my treatment if I get it wrong. But yeah, I mostly did standard of care, so chemotherapy, radiation, and then I was on the Trident trial, which meant that I started Optune along with radiation at the same time. So I did truly just standard of care for the most part until they found my potential recurrence in 2022. So that's when my neuro-oncologist at the time decided that it probably is likely that Temodar wasn't working as well for me. So that's when they switched me from Temodar to my immunotherapy, which is Keytruda. So since then, I've been on Keytruda and Optune mostly, and then I guess I'm getting like off-label metformin, and I think that's all that I'm doing. I will say I also get Prozac and Keppra for the seizures, and Prozac for my mood. So that is my full regimen of treatment right there, unless I'm forgetting something. And outside of that, I think everything that we discussed is like the toolkit of a warrior in my mind. Like, use your village, be open about, like, share what you need to share, like, don't hesitate to ask for help. And yeah, just, get all the help you can possibly get to boost up your positivity and your resilience. It's a shitty disease, but we do what we got to do to make the most out of life.
Thank you, Janice, for being so honest and open about your background and your story. I want to highlight that, Janice's story is her story. It's going to be individual. One of the things I talk about is I want, of course, all my patients to have Janice's story, but there are positive and negative prognostic factors that are going to affect your journey from the very beginning, and it'll change as time goes on. So I often counsel, like, the better you're doing, the better you're going to continue doing. The worse you're doing, the worse things will continue to get. And so the better you're doing means quality of life really has to be optimized. And for Janice, from the beginning, she was very intentional, especially if you read her book, you read about how she's very intentional in making sure her quality of life was considered and optimized, and she did treatments to that end. For her, Optune really worked very well, and she was able to fit it into her life not for everyone. And I've seen patients who've done Optune and it hasn't worked for them, but they've also just been miserable through it. So what worked for Janice may not work for you, but what's important, the bigger picture, is that there are factors in your tumor, like your mutation status, or how well your surgery was, or what treatments are accessible for you, and there are factors that are good and there are factors that are bad. So your oncologist and your team would be able to give you the best sense of where things are going, but often you have to talk to them about it.